I'm an oncologist. I look at PSA results every day. I explain them, I guide men through decisions. But if I log in my patient portal tomorrow and see my PSA rising from 1 to 6, I would feel that punch in my stomach too. The difference is I know the traps, and I also know the sequence that protects us from them. In the next few minutes, I'm taking off the white coat and showing you my personal playbook. If my PSA rose tomorrow, here is the exact 4-step sequence I would follow, and the 1 step I would not anyone let skip. Step 1. I do not act on a single PSA test, I confirm it. Most PSA spikes are just noise, inflammation, a recent lab variation, or even a very heavy workout. If I had no red flags like fever, chills, burning during urination, and connected pelvic pain, I would recheck the PSA in 2 to 6 weeks. Not the next day and not in 6 months. And also, if I had infection, I would see the doctor immediately. There's easy way to treat this. 48 hours before my second blood draw, I would follow these simple rules to not make the test falsely positive. No ejaculation, no heavy cycling, and I would not let my urologist to do the rectal exam before they take the blood. I want the quietest, most accurate baseline possible. If the repeat PSA drops back to normal, that's great. We breathe a sigh of relief. But if it stays elevated or rises, we move to step 2. Step 2, I stop staring at PSA number and I demand context. I want to know how large my prostate is. Big prostate makes more PSA, that's just basic biology. So I would get an ultrasound or MRI to find the exact volume of my prostate so we can look at the PSA density. PSA density is basically the PSA divided by the volume of the prostate. In general, lower density is reassuring and higher density raises concern, especially if PSA is rising rapidly over time. We call that PSA velocity. But even with the high PSA density, I will not go straight to biopsy. I want to see a map. Step 3 is a deal breaker, multiparametric MRI, magnetic resonance imaging that should be done before any needles touch the prostate. The old approach was random ultrasound biopsy. Basically, it's sampling blindly, hoping you will hit the prostate cancer lesion. If MRI is available, I would not do a blind biopsy as my first move. And this is not just my opinion, this is supported by major evidence from studies. In PROMISE and PRECISION trials, MRIs used upfront improve how we triage men, helping avoid unnecessary biopsies for some and improve targeting when biopsy is truly needed. This is exactly what we need. So I want an MRI to give me a PI-RADS score. PI-RADS is a grading score that tells us how suspicious the lesion looks like. If the MRI is clean or low suspicion, many men can monitor their situation instead of rushing into biopsy. This depends on overall risk. Now, what if you live somewhere without easy access to MRI or your PI-RADS score is borderline? I would ask my doctor for secondary bridge tests like PHI test or 4K score. These tests give us clues if biopsy is really necessary. Do not let the biopsy be automatic. But if MRI shows clear suspicious target, we've earned the right to biopsy because now we can aim. European guidelines strongly recommend MRI before biopsy in all biopsy-naive men. Step 4, if MRI shows suspicious lesion, I'm getting an MRI-guided biopsy, sometimes called as fusion biopsy. This is the difference between throwing darts blindfolded and walking straight to the bull's eye. Furthermore, I would ask my doctor about the approach. Many centers are now moving from transrectal biopsy to transperineal biopsies. What does it mean? The transrectal biopsy goes through your rectum, while transperineal biopsy goes through skin. And this reduces the risk of severe infection. The PREVENT trial looked directly to compare the transperineal biopsy and transrectal biopsy, and they looked into infectious complications. Not every center uses it, but you are completely allowed to ask. You deserve the same exact standard of care that doctor would demand for himself. So here's the playbook: confirm the PSA, add context with density, get a map, the MRI, and do not let fear choose your next step. We are building a community where men take control of their health, and thank you for being a part of it. If this playbook made sense, hit subscribe. And if you want something practical, I made a 14-page PSA guide. Everything in it is free in my videos. The guide just organizes it. If you want a printable checklist, it's a paid optional guide linked below. Now this is critical. The next trap happens if somebody tries to skip the steps and rushes into the blind biopsy out of fear. In my next video, I will explain you exactly how that happens, what risks nobody explains, and what I would demand instead. Click the video on your screen right now. I'm Dr. Chovanec, and I'll see you in the next one.